Thank you, and good afternoon, and welcome to this CME program. And a big welcome to our global live streaming audience too. The title of, or the theme of the presentation is Optimizing Immunosuppression, Precision Medicine, and Big Data, the required path for innovation in transplantation. Now, you will notice that these are buzzwords, precision medicine, big data, but let me assure you, we're going to have real content behind those buzzwords. My name is Flavio Vincenti. I'm chair of this program, and my co-chair is Doris Segev. He has lots of titles. Maybe I'll just mention one: Director of Epidemiology Research Group in Organ Transplantation, because it's probably going to be most relevant to the presentation of today. I hope so anyway.
I'm just a simple country surgeon.
Yes, I always say that. The next slide is the learning objectives. And I will start with the first learning objective. That is to identify modifiable and non-modifiable risk factors for allograft loss in patients receiving a kidney transplant. And this is a slide that I think you may have seen before. It's a popular slide to show that the attrition rate in the first year after transplant, whether for deceased or living donor, has decreased tremendously from 1989, because that marks the beginning of the introduction of the very potent triple regimens that we have now in induction therapy. The problem is we haven't made that much progress beyond that. 1 to 3 years, 3 to 5, 5 to 10, the yearly attrition rate has improved, but really very modestly. Now, if we want to abide by, the holy grail of transplantation, that each kidney will last for the life of the patient, or each patient will receive one kidney that will function for the rest of their life, we really have to change these metrics. And I'd like to ask Dr. Segev, what's his perspective of this data?
Yeah, so even already on the first slide, we have an example of big data and how we use big data to inform our knowledge of what's happening in transplantation and hopefully lead us to where we need to put our efforts. And here you see that just using national registry data on a very, very coarse overview level, we can see that we are getting better with 1 year survival, but we're not getting better with improving long-term survival. And the next steps of these things are to look more granularly into which patients are losing their allografts late, which patients are not losing their allografts late, and can we predict what road the allograft is on based on biomarkers and all this other data that we can gather on the patients, so we can intervene before they lose their allografts at 3, 5, 10 years. And we're going to talk about novel new methods for making these more precise estimates for patients.
So what about risk stratification, Dori?
Yeah, so in general, the purpose of risk stratification is to individualize both the immunosuppression and the management, both pre-transplant management and post-transplant management of transplant recipients, both in terms of evaluating donor risks. And as you know, we already have some coarse tools like the KDPI to evaluate donor risk, but there's much more to donor risk than that, as well as the recipient risks, both from immunological risks that the recipients have and non-immunologic risks like medical risks and vascular risks. We know that when we look at late-stage allograft loss, there are a whole number of factors that can contribute to these things. And oftentimes they cause sort of a cascade from an early event, like a preformed donor-specific antibody, that then causes an antibody-mediated rejection, that then causes a cascade down the road. These are things that can happen a little bit later, so you have a functioning allograft, but then you have a patient that has little bits of time where they're non-adherent to treatment, as all of us are non-adherent to things in life, and this causes the development of de novo donor-specific antibody. Again, these stimulate the immune system and cause chronic injury to the allograft. On the other side, the non-immunological side, there can be the characteristics of the donor. So the donor may have already had some sort of nephron parenchymal injury, cardiovascular comorbidities in the donor that then manifest themselves late in the life of the allograft. And there's the recipient factors as well. So recipient medical conditions like diabetes, hypertension, CNI toxicity, infections. We know infections stimulate further antibody issues, et cetera, and all of those things can affect the allograft function down the road as well. And so what we want is we want to think about and better elucidate what are the risk factors that, in particular, that are modifiable. So, for example, immunosuppression, we don't do a very good job of, we use relatively standardized, non-personalized immunosuppression regimens, and we don't have a very good way of being vigilant about whether the patient is under immunosuppressed or over immunosuppressed. Donor-specific antibody monitoring and intervention for DSA. In patients who have subclinical histologic findings in protocol biopsies, how we address those. Immunosuppression-related toxicities leading to nephrotoxicity, cardiovascular, metabolic complications, again leading to more, we need better diagnosis and treatment of NODAT and hypertension, and non-adherence where we need better predictive metrics and better patient education. So all of this we need to keep in perspective with regards to the new kidney allocation system. The kidney allocation system in the US was changed in 2014. There are changes to allocation systems globally, some of which have used similar principles. The overarching principle was to give advantages to patients who are expected to have the longest survival, which means longevity matching, to put the new parts into the new car and the used parts into the used car. And in addition, there was a priority for sensitized patients that, while it was a relatively small thought in the overarching theme, ended up being a huge impact in how CAS has changed allocation for various patient phenotypes. And it replaced SCD and ECD with the sort of more granular and refined KDPI metric. As you all know, these are the variables that go into the KDPI. These KDPI correlates and associates with post-transplant outcomes, and so the worse your KDPI is, the worse on average your outcome will be from the transplant. Interestingly, and in a worrisome way, there is an out-of-proportion relationship between KDPI and discard, so that as you get to the KDPIs of 40 or 50%, you start to see 30% discard rates. As you get to KDPIs of 80 to 90%, discard rate approaches 70%. So we are afraid of KDPI, and one of the reasons we're afraid of KDPI is that we look at all of these things on average. We have a score for the donor, we have a score for the recipient, but we don't know how the interaction of donor factors and recipient factors play in. And it turns out that there are patient phenotypes for whom a high KDPI would be a wonderful organ, and there are patient phenotypes for whom it would not be a wonderful organ. We can do some of this with the available registry data, but as we add more biomarker and biological data, we can do an even better job of this. It's important to know when we counsel patients about their therapeutic options that the new kidney allocation system did have winners and losers. Anytime we change allocation, we are moving organs from one set of patients to another set of patients. For example, we increased by 19% the transplant rate for African American candidates, which is great. As you might imagine, we decreased the transplant rate for non-African American, non-Hispanic candidates. So it's important, if you're one of those phenotypes, to know where you stand. We increased transplant rates for female candidates by 9%. We increased particularly transplant rates for those who are 18 to 40 years old, and even some for those who are in their 40s. Again, by shifting to this emphasis on longevity matching, where good organ offers are going to go to the patients that we think will live the longest. However, if you're over 60, over 70, you've now taken a huge hit in your availability of a solid organ, of a kidney transplant offer. And that means that we need to be thinking particularly for those patients in terms of how we can make more marginal organs work for those patients. Flavio encouraged me to quote ABBA for you. The ABBA song, "The Winner Takes It All," was actually a song summarizing the new kidney allocation system and the impact on high CPRA patients. And what you see here is that the one line is what their access was before CAS, and you see over time since the initiation of CAS, those are the PRA of 100%. More than 10 times the access to kidneys now that they had before, and actually those with PRAs under 97%, and what used to be the privileged 80% and higher group, actually the 80 to 90% group took a big hit as a result of CAS, and the 90 to 97 group kind of broke even. And if you look at this sort of in general, this is the proportion of kidney transplants that we were doing before CAS in people with a PRA of 100% was 1.6%. Today, post-CAS, 14% of the transplants that we're doing are in patients with a CPRA of 99 or 100. So we've made a huge shift in who gets transplants, who's been the winner and who's been the loser from CAS. And this is all really important to keep in mind when we think about our patients, the organ offers that they get, and how we can optimize their treatment.
So let's see how the themes of this program apply to a patient case, and we'll follow this patient from transplant and see what kind of issues arise with the follow-up. So this is a 60-year-old African-American woman who has been on hemodialysis for years, PRA 58%, is offered a kidney with a KDPI of 68%. Receives induction with thymoglobulin and then maintained on triple therapy, tacrolimus, MPA, and prednisone. The kidney improves rapidly in function, and by 3 weeks, her creatinine is ranging between 1.2 and 1.4 milligram per deciliter. In the follow-up, though, at 3 months visit, on screening, she's found to have BK viremia with 20,000 copies. So the questions here at this point is, what do you do? Do you do nothing and wait for the next month's BK viral load? Number two, do you start cidofovir, 0.25 milligram IV times 5 infusion every 2 weeks? Do you discontinue MMF and convert the patient from tacrolimus to an mTOR inhibitor? Or do you decrease MMF to 500 milligram twice a day from 1,000 milligram twice a day, and you repeat the BK viral load in 1 month? Number E is that you're not sure exactly what should be done. And now you can vote for that. Okay, so number 4, most people have voted, and I would agree with that, right, Dory? Because I think the first approach with a patient that starts to have BK viremia is to decrease the immunosuppression. In this case, the patient is on 1,000 milligram of MPA, and one can drop it by 50%. And then if the patient goes in the right direction, it's great. If the patient goes in the wrong direction, then maybe you can apply, cidofovir or other maneuvers or further decrease the immunosuppression. So the next follow-up at 6 months, the BK viremia, we've done that. We dropped the MMF, just like you have voted. Viremia is cleared by now, but however, the patient's complaining, insomnia, tremor, memory loss. She complains about all the pills she has to take all day long, twice a day, 3 times a day. And then finally wonders whether she should have been on dialysis. Her life was simpler and maybe better, according to her. Now, the tacrolimus level is not high. It's 5.3 nanogram per ml. And remembering, again, she was sensitized and she's African American. So at this point, you have another set of decisions to make. Well, you stay the course, you hold her hands, you give her some reassurance. Number 2, you discontinue tacrolimus and convert the patient to mTOR inhibitors. Or you convert the patient to belatacept, not because I'm up here. And number D is try once a day long-acting tacrolimus. Maybe, once a day, that will help her out with the evening insomnia and so on. And number E, I'm not sure. So what would be your next step here? You can go ahead and vote. Well, what do you think, Dori, about this approach, once a day tacrolimus? Well, personally, first of all, we put this question so there wasn't right and wrong. The mTOR in somebody who is highly sensitized, etc., in this patient may not be a good approach. Belatacept, well, she's complaining about a lot of things. She's going to complain further if she comes every month for infusions. But if you're, well, she could. Then you have to make sure she has good veins. The other thing, though, is you have to make sure she has good veins and so on. That could be a potential issue. The once-a-day tacrolimus, if she is going to improve her compliance, that potentially may make sense. All I'm saying is that I think the worst thing is number 1A, because this patient is sending you a lot of red flags. You really have to be aware that this patient has non-adherence written all over her. And therefore, whatever maneuver you do, it has to improve the potential for non-adherence. So that's why there may not be a perfect answer, but not doing anything, I think, would be the least good answer. And so now we go to the next follow-up. 2 years later, she comes in with a creatinine of 2.1, a urine protein creatinine ratio of 1.2. Now she's developed DSAs. And finally, it comes out that she has been skipping her medication and she has been non-adherent. So our suspicions are correct at this point. So this patient, if I were to biopsy her, I guess she would have maybe chronic antibody-mediated rejection, maybe a mix with cellular rejection. But this is a kidney that has trouble written all over it, and this is a kidney that's going to be in trouble going down the stretch. So, Dori, where did we go wrong in the management of this patient?
Wow, that's a tough question. Well, so with regards to the big data, one of the questions is, can we use big data algorithms to predict which patients are going to go down one road, which patients are going to go down another road? Obviously, one of our biggest challenges in transplantation is adherence and non-adherence, and we don't really have good tools for evaluating which patients are going to be adherent and non-adherent, other than late teenagers who we all know are going to be non-adherent, and actually 40% of them will lose their allografts. But I think even more important than that is which patients are at risk of being affected by short bursts of non-adherence. And, for example, on the liver side, non-adherence is going to be much less of an impact than on the kidney side. And are there patients who could get away with, if we're worried that they may be non-adherent, could get away with little bursts of non-adherence? And I think that's where big data is going to play into this.
So, in terms of stratification, basically, historically, we've had two choices. Before big data and biomarkers, we're either stratify patients for the risk of nephrotoxicity, or we stratify patients based on immunologic risk. And then we say this patient has to have depleting antibodies, and we have to use triple therapy, and so on. And these choices are not pulled out of a hat. They're based on outcome studies. And over the period of time, the outcome studies may evolve. We may have new technologies that make us better understand the relevant information behind the outcome studies. For example, this is a very famous article published by the Australian group where they took a number of patients who had kidney pancreas transplant, biopsied them several times, once a year after the first year, and then analyzed the histology. And what they found that at 10 years, and progressively between 1 year and 10 years, there was less evidence of acute rejection or immunologic injury, but there was more evidence of what they at that point considered to be CNI nephrotoxicity. Now, I think this study basically put in motion this whole concept that we need to minimize CNI, and we need, if possible, even withdraw CNI to minimize this deterioration in kidney histology and function. The problem with this study now, as we look back, because looking back now it's easy, one, it was a cyclosporin-based immunosuppression. The exposure was high because these are kidney pancreas transplant. And then the other thing is that we didn't have the new technology. We didn't measure DSA. We didn't look for C4D. So the specificity of this finding that they associated with CNI nephrotoxicity may not have been correct in today's technology. And in fact, this is reflected by two studies, and I'll give you just two quick ones. One is called the DECAF study. This is a multi-center trials where they took patients, about 150 patients, who up to 2005 had normal function. And when the renal function deteriorated subsequent to that, they biopsied them. And they applied the new technology of looking at histology, doing C4D, getting DSA. And lo and behold, the top group that did the best were the patients that had been considered to have CNI nephrotoxicity. And progressively, if patient had DSA only or C4D only, and the combination of DSA and C4D, which actually were the majority of the patients that had troubled kidneys, those patients had progressive deterioration in renal function. So all of a sudden, chronic antibody-mediated rejection comes up to be the most important. And this is a study from Phil Halloran's group where they followed 350 patients, 50 of whom over a period of time lost their kidneys, and again applied the same type of analysis. What they found that almost 65% of patients, the cause of graft loss was chronic antibody-mediated rejection. There were some polyoma, glomerulonephritis, and when you look at this, you say, hey, something is missing. What is it? And what is missing is that none of these patients were reported to have lost the kidney from chronic CNI nephrotoxicity. And what's important also is that the patients who had this chronic antibody-mediated rejection, half of them had non-adherence. So all of a sudden, we have two important, well-done studies says the most important cause of chronic graft loss and chronic deterioration is chronic antibody-mediated. So now that we kind of settle, we say, okay, this is all settled data, then we get another study that puts all this in balance. And this is a Mayo Clinic study, and I really like the study. I've complimented Mark Stiegel for it several times, because the Mayo Clinic has a group of patients, mostly living donor transplant, very adherent. They come back every year. I have a patient in San Francisco who was transplanted there, and every year she makes the trip back. And then they biopsy them at day 0, day 1 year, 5 year, 10 years. And what did they find? Most of the lesions were non-immune. Hyalinosis, mesangial sclerosis, global glomerulosclerosis. In fact, only 12% of those kidneys had transplant glomerulopathy or moderate to severe interstitial fibrosis, which also has been associated with antibodies. So, basically, it depends which group of patients you're studying. So my question to you, Dori, is graft failure a function of the zip code or who you are?
So that's a very good question, and I would say it's a function of the zip code and a lot of other things about the patient. And what we're learning is that the same patient treated with the same allograft, if you put that into a different patient at exactly the same time, living in a different place with different familial risks, different genetic risks, we're going to see totally different things happening with that allograft. So in studies, as you've reviewed, the causes of the late allograft failure have varied based on the populations that we're looking at. If we compare the Mayo series to, for example, a series of all patients who were transplanted across pre-existing DSA, we would probably see a very different histological picture in those. It's interesting that at 10 years, it's not that high of a proportion of patients that are developing AMR and are developing immunologic risk, but that there's also all of this other risk for the patient. And perhaps if the patients were adherent and the patients were not at risk for diabetes and did not develop these end-stage or these end organ diseases, they may not have the same allograft outcomes. One of the things we can do, so obviously we can't modify somebody's biology, but we can better understand their biology and then select their treatments. How often do we biopsy them? How often do we do protocol biopsies in them? What do we do with their immunosuppression? Is this somebody who we should immunosuppression minimize? Is this somebody who we should not, who would be a big mistake to immunosuppression minimize? For example, when everyone was excited about steroid minimization, it became very clear that there were some subgroups that would not be good candidates for steroid minimization. Can we do a better job than just sort of a course gestalt of how we should treat these patients?
So, while you were speaking, there is a question that came, said, well, what about the Tregs in this patient? Do they play a role? And I just want to have a quick, we know what Tregs do, and we know that in certain instances, there have been reports that patients who have chronic rejection have lower numbers of Tregs. But therapeutically, can we affect the course of patients like her with Tregs, either by infusion or by pharmaceutical expansion, by giving them a drug that expands the number of Tregs? I think that's a complex question. It's possible that Tregs play a role, but whether we can use them therapeutically and intervening in a patient like this one, at this point, it's unclear, frankly.
So I'm glad you took the complex question. I'll take the question more suited for a surgeon, which is, where do you put the kidney? This really came through here. And my answer to you is in the recipient. So I want to go through a few examples of things that we don't typically pay much attention to, or maybe that we're just starting to pay attention to, that seem to be really important in risk prediction in patients. One of these things is a concept of frailty. This came from the field of gerontology. Our gerontology colleagues are always looking for domains of risk and biological understanding that transcend what we know about demographics and comorbidity and get more into biological processes. And it turns out that as you get older, you get an inflammatory physiotype, and that inflammatory physiotype is associated with clinical entities like exhaustion and decreased walking speed and unexplained weight loss and physical activity and decreased grip strength, sarcopenia, and those sorts of processes. And in older adults, this is highly predictive of what's going to happen to patients. And there are patients who are frail who have no comorbidities, who do very poorly, and patients who have a lot of comorbidities who are not frail, who do quite well. So this is an example of a domain of risk that we have recently started looking at in transplantation, and it turns out that this domain is associated with a lot of things that can happen to our patients, not just by correlating the clinical picture of this, but by looking biologically at the inflammatory markers associated with the frailty phenotype, like IL-6, TNF-alpha, C-reactive protein. It turns out that if you have certain patterns of these inflammatory phenotypes, you will be at a higher risk of mortality and other post-transplant outcomes. Other examples of things that we don't typically hear about very often, but that in the recent 1 or 2 years we've seen literature talking about, is the impairment of physical function, cognitive impairment and its relationship to allograft loss, delirium and its relationship to allograft loss, health literacy as an example, and community health as an example of things that the patient may not really have much control over, but if we can modify these things, then we can also improve the outcome of the patient. So rather than just looking at models that take into consideration age, diabetes, and cardiovascular disease, there's all these other factors that we haven't looked at in the registry. And a little bit later, I'm going to talk more about the biological factors as well, like the omics and the role that they play.
I have a question that came through. It says, since we have different medical records, how do we collect data and put it all together?
Yeah, that's, right now in the US, we have a standardized data collection system through the OPTN, and we collect some data through there, and it's been very useful. And you see every month in AJT at least one paper based on OPTN, UNOS, SRTR data that has guided us. But I think moving forward, since we have so much more granular data in our electronic healthcare systems, we need to be able to find a way to integrate those data. It seems like there are a few bigger players in the electronic healthcare record systems, and maybe one first step is to gather data through one or two of those bigger players and then find ways to incorporate all the other transplant centers. It's not something that's been done very much yet, but something that I really hope will get done to give us more granularity on patients.
What about this study?
What about this study? You were supposed to talk about
fine.
this study.
So, well, this slide, what this study tells me, patients who, over a period of time, they collect their TAC level, and if they deviate more than 2 or 2.5 or 3 standard deviation, they have greater risk of graft loss. What this tells me, it expands our definition of non-adherence. Non-adherence doesn't mean you don't take your drug. If you take it erratically at different hours and you get different levels, high sometimes, low other times, then you are at risk. So we have to be more rigorous when we see patients in the clinic and the follow-up to make sure not only they take their medication, but they take them within reasonable amount of time so exposure doesn't differ too much.
And it's not only whether they're taking the medications, but there are some patients that we don't do a good job of finding stable TAC dosing regimens in. And for example, I'll give the example of HIV positive recipients. In the early days of HIV positive transplants, because of drug-drug interactions between the HIV drugs and the CNIs, dosing of CNI was really, really difficult in these patients. And even if they did exactly what we told them to do, we would find really erratic CNI trough levels, very difficult to manage them, which caused 3 times the rejection rates. Now that we figured that out, and we now moved to HIV meds that don't interact with CNI metabolism, we see those rejection rates go away. So that's an example of how a patient may want to take their medications adherently, but we just don't do a very good job of telling them what to do.
Yeah. Good. So what I want to discuss very briefly now is a study that was reported at this meeting. There aren't too many very large studies of patients taking different combination of immunosuppression. In fact, over the past few years, they have dwindled. This is actually, the Transform is the largest study of its kind, 2,000 patients. Designed to determine whether everolimus with reduced CNI performed as well as full CNI with MPA. The primary endpoint was rejection and EGFR below 50 ml at 12 months. And they, well, let's move it. The efficacy endpoints between the two groups of patients reduce CNI with everolimus versus full dose CNI with MPA. There were no significant difference in efficacy between the two groups. But one thing became clear, that infectious complications, especially viral infections, were significantly reduced. CMV infections were reduced, but particularly in patients at the greatest risk of CMV infection, donor positive, recipient negative, as well as BK viremia and BK infections. So I think mTOR inhibitors have been recently recognized, though immunosuppressive as such, that they are also antiviral agents. And there are many mechanisms. Maybe one of the more important is that they allow expansion of memory-specific antiviral cells to expand during the infection and to control the infection. So as I was starting describing the TRANSFORM study, there was a question is, what's the difference between everolimus and sirolimus in terms of safety and so on? And frankly, these two have not been compared, so one can speculate. The major difference is the half-life of everolimus much shorter than sirolimus. So potentially, you can maneuver a tiny bit more easily because you can very quickly change the dosage or stop the medication if you have an issue with the drug. So in terms of safety, it's just, I think, a quicker response may alter the course of the side effects associated with the drug. So the third learning objective is to explore the impact of precision medicine and big data on the future of transplantation. So here we'll say what's happening in 2018 and what will define success in 2025. I think Dori Segev has better vision than me. I'm astigmatic, so he'll be able to look at 2025. I'm going to look just under my nose what I see today. And I have a slide. What doesn't work, what is not very successful in 2018. Desensitization and AMR therapies. They are okay, but they are only very partially successful. Many patients continue to have DSA after transplant despite desensitization. De novo DSA, when they occur, they can be devastating to the kidney. Frankly, our therapies don't completely suppress the network that leads to the formation of the antibody and to counteract the effect of the antibodies. Managing subclinical inflammation. When we do protocol biopsy, we see a lot of patients who have subclinical inflammation, especially the combination of subclinical inflammation in areas of fibrosis. We don't know what kind of therapy and how effective it can be to reverse this inflammation. We know, though, that patients who have inflammation longer term have poorer GFR. There have been several studies, including from Mayo Clinic and Rosmarin. We are continue to depend on CNI regimens. I mean, there's going to be a group of patients that will always require, or for a long time in the future, that will require CNI. But I think a good number of patients probably do not require CNI if we know how to apply CNI-free regimens. And tolerance trials, let's face it, have been disappointing. We want to induce tolerance, but so far, this bone marrow intervention, infusing bone marrow, conditioning the patients, and so on, you do get chimerism in some patients. At this point, in my view, the cost may be too high to account for or to make up for the benefits. Now, beyond clinical stratification, what else can we do for better selection of patients, let's say?
Yeah, and before we move on, I want to address a couple of questions that came in that are related to this. So one thing I want to clarify here is that the patients that we should be transplanting are patients that we think will benefit from a kidney transplant. So patients where we think the outcome post-kidney transplant will be better than the outcome had they not been transplanted. And there's a lot of complexity in that. We are going to talk about, and we have been talking about, a bunch of risk predictors. One thing I want to be very clear is that just because something is a risk predictor, I'm not saying that this is something that should exclude somebody from getting a transplant. So a question came in about frailty. Even if the outcomes for frail recipients are worse than non-frail, they still survive longer than staying on dialysis. How do you then decide whether or not to transplant these patients? I think the more we know about what somebody's risk factors are, the better we can treat them, the better we can choose an immunosuppression protocol, the better we can say, well, maybe this patient isn't the greatest candidate for desensitization. Desensitization has worked really well in some phenotypes, but hasn't worked really well in other phenotypes, et cetera. So I think as we talk about what we are learning about as risk predictors, I just want to be very clear that these all give us as much insight as we possibly can into the patients, the risks they bring with them, and then on the biological side also, what are which patients are good targets for which biological agents, depending on what mechanism it is that we think is going on. Now, are we there at the mechanistic level? We're not nearly there, but we're starting to gather sort of more broad-based data based on biomarkers to better understand those mechanistic things. So, one of the questions is, can we go beyond clinical factors and apply genomic biomarker information in selecting the treatment that improves clinical care and outcomes in transplantation? So again, not necessarily selecting the patients for transplantation, but selecting how we treat them with immunosuppression, how often we follow them, how often we need to do protocol biopsies, whether these are good candidates for different treatment protocols, whether these are good candidates for different types of donors. The need is to have biomarkers that are accurate, that are reliable, and that are associated with events and endpoints that may lead to better patient outcomes. And we say that up front because we are just in the early stages of biomarker exploration and discovery and development. And I don't think there are perfect biomarkers for any of these things right now, but I think that we're learning more and more for this. And so some of this comes to the difference between personalized medicine and precision medicine. And I just want to give a little example of this. So by a show of hands in this room, how many people would give every single kidney transplant patient that you have the exact same immunosuppression regimen? Okay. How many people would give low-risk patients, however you define them, a different immunosuppression regimen than who you consider to be high-risk patients, by show of hands? Okay, so every one of you practices some sort of personalized medicine, right? We get a gestalt about the patient, and we say either we follow strict rules like the KDIGO guidelines, or we create rules in our center, or we just say, I just feel like this patient is higher risk or something, and we treat the patient accordingly. So that's a very coarse, sort of broad-based approach to doing this. What we would ideally like to do is to get precise personalized data from the patients about not just their demographics, but the biology of the patient, to really create precise regimens for every single patient. Because I think if I would ask how many people here have used more than 20 different immunosuppression regimens in the last year, I wouldn't give very many hands, right? It's probably, we all sort of sit around 3, 4 maybe immunosuppression regimens that we'll choose according to the phenotype of the patient. But if we really want to practice precision medicine, we should choose an exact set of immunosuppression that reflects the risk factors and the biology of the patient. Were we able to do this? And so this comes into choice of induction agent. So today we're using PRA, donor-specific antibody, development of DGF, et cetera. We could go way deeper by understanding much more precisely who the patient is, and then not just choosing the agent, but choosing the dosage of the agent, et cetera. Again, we choose the CNI based on sort of these large, broad-based areas. We choose who is a good candidate for early steroid withdrawal based on these broad-based areas, choice of antiproliferatives, et cetera. These are decisions we already make today to, again, choose one of those 3 or 4 immunosuppression regimens. What we really want is treatments targeted to the particular patient on the basis of genetics, biomarkers, phenotypic characteristics, everything we know about them that then maximize the efficacy of the immunosuppression and minimize the toxicity. So this is a recent review article of Transplantomics. So basically all of the different omics that we've been looking at in the last few years in transplantation, genomics, transcriptomics, proteomics, cell-free DNA stuff, which has become recently very hot, and taking all of this information that we can gather about somebody, putting them into computers that can handle large-scale data way better than any of us can handle large-scale data, like complex neural networks, which I'll talk briefly about, and then using those to pattern match. So neural networks are really, really good at pattern matching, and to say, based on this pattern, this is what we think is going to be the outcome for the patient. using those to improve donor and recipient matching, using those to tell us how best to monitor allograft function, how best to how a patient we think will respond to given treatments, and then also on sort of the more exciting discovery phase of things to create new therapeutic targets. So the more we understand about the biology of what's happening in the patient, we can then we say, well, there's a problem here, and we can create therapeutic targets for that. This is an example, a seminal paper that Mini Sarwal put in the New England Journal back in 2003, telling us that you can use DNA microarrays, and you see a lot of the different things that were part of the microarray that was looking at, to profile the heterogeneity of renal allograft rejection. And what we mean by that is there's only so much we can see histologically. There is a lot more going on mechanistically in the patient than what we know about histologically. And if we understand the mechanisms there, then the treatment will be very different. So, and Phil Halloran has looked into a lot of this as well. On the antibody-mediated rejection side, we know that there are patients that respond to certain AMR treatments and patients that don't respond to certain AMR treatments. And if we learn more about the molecular fingerprint of what's happening in different AMRs, different cellular rejections, not just what we see histologically, we can then choose the right treatment for this. We can also, so this is another example of the work that Phil Halloran and their group do, looking at what do we know about the patient clinically and histologically, and then how much more can we learn from the molecular microscope. And it turns out that we can learn a lot more from the molecular microscope. So instead of just having a pattern where we treat certain levels of severity of cellular rejection with certain drugs, we would understand what's really going on with the patient and be able to target them to the right drugs. Also, these technologies are being used for non-invasive monitoring. Cell-free DNA is an exciting new area where we may be able to not have to actually, obtain tissue from organs, but we'll be able to monitor what's happening with people in a non-invasive way, and some of those may help us it may help us trace longitudinally what's going on with the patient. And so then instead of treating just something that we happened to biopsy a couple months after we noticed something was going on clinically, we already have a longitudinal picture of what was happening there. This is an example of we talked about that maybe we can learn biologically something about a patient before we take them to transplantation to select who we think will be at higher risk. This is a study that Mini Sarwal published in Science Translational Medicine, looking at recurrence of FSGS, which is a major problem, particularly for those who have FSGS, and looking at an antibody panel to try to predict which patients are going to be at the highest risk for this recurrence. And again, in those, you may want to treat them differently. You may want to target them to certain therapeutics. This is not just going on in transplantation. There is a lot of really exciting work in using these big data-driven machine learning algorithms in other fields. So here's a really exciting example of computers basically reading radiographs. And so what they can do is the computers outperformed radiologists in reading the radiographs because they fed them so many of them and the clinical picture of what happened to the patients, and they didn't even need to tell the neural network how to figure this out. They just dumped all this stuff into machine learning algorithms that set themselves up in the way our neurons set themselves up in our brain, and then they just plug this through into the neuron, and it turns out that these things can do a better job of predicting of analyzing diagnostic material than we can. Another example is from skin cancer detection. They can take a picture of a skin cancer, plug it into a neural network that learned on its own how to differentiate between different skin lesions and have a much better prediction rate of which are malignant and which are non-malignant, what the characteristics are of the skin lesions, than the actual providers looking at these things. And this is an area of computational science that we have not particularly explored very well in transplantation, which is that of so we're very good at telling a computer, well, what we know about C1q, and so we can throw C1q into an algorithm, or we know about race, or we know about diabetes, but to just let the computer sift through millions of data points and figure out for itself patterns that we may not have been able to have seen is going on in medicine. I'll give you an example of taking a lot of data and putting it together in the form of a clinically useful risk prediction tool. I'd like to thank Alex Lupi from the French group for giving me these slides to talk about his work in what's called iBox, which is a computer-driven prognostication tool, where what they've done is they've fed into the computer all of these data on any risk factor that they could possibly pull on the patient, some histological data that they pulled on the patient, donor-specific antibody data, etc., threw everything into a computational engine, and then out from it comes a risk prediction machine. So here you see all of the data that go into it: histology, DSA, biological parameters, clinical parameters, etc., into a machine learning algorithm. And again, I could talk for hours about machine learning. When I was in college in the 80s, we were doing machine learning algorithms. It's just that machines were so slow and so unable to handle data that they never became very useful. But now today, machines can handle so much data so quickly that we can really have it match patterns. And it turns out that when you do this, and then you validate it. So Alex has validated this on at least 5 transplant centers worth of data, thousands of patients. It turns out it validates very well. So as much as we can enter into risk prediction models, we can then get as much clinical data as we possibly can out of it. The last example I wanted to talk about with regards to big data and its impact on transplantation is for patient decision making. And this is just a very simple example of this. So we have patients who are offered organs on a regular basis. If you sit on a kidney waiting list, one of your biggest challenges is somebody calls you with an organ offer. Do you take this organ offer today, or do you wait for the next best available offer? And how are you going to process this decision? This is not an easy decision to process. You need to draw data from the entire National Transplant Registry about how you're expected to do on dialysis, how you're expected to do waiting for the organ. You're supposed to draw data from outcomes from a given organ, what the waiting times are, where you are, et cetera, et cetera. And different things can happen to you. And we can use, this is an example of a Markov decision process model, which in computational science we call stochastic modeling. So you're actually modeling decisions that patients make, and what will result from that is you can enter information about a patient and you can help them with a given clinical decision by saying, if you decide A, this is what we expect your outcomes will be, and if you decide B, this is what we expect your outcomes will be. So not only helping us choose immunosuppression and choose, patients who are eligible for transplantation and things like that, but once a transplant patient has to make their own decision, using these computational models to help the patients make decisions as well.
Good. So I got a couple of, there are 2 questions that are really good. One of them I really like. The first one was, will precision medicine replace clinical trials? And there is a very good answer to that. Precision medicine will improve clinical trials.
Absolutely.
And in fact, I have a list of drugs that failed because precision medicine was not applied. Going forward, you cannot do with an immunosuppressive agent the type of trial we used to do in the past, meaning get everybody in or any comer in. No, you have to select. And the other question, and I'll come to belatacept because that applies to that. The other question that was sent was, is this the gateway, precision medicine, to artificial intelligence? Some robots will replace us. Well, it's very possible that in a few years, instead of having the 2 of us, you're going to have 2 robots doing this. So maybe yes.
I can only hope so.
Okay, good. So let's move to precision medicine. Basically, this is a good example of a drug where it could use precision medicine. So belatacept, there was a paper in New England Journal that showed that 7 years patients on Bela had better graft and patient survival. They had much better GFR. They did not develop DSA, much lower incidence DSA. The only problem is that at the very beginning, a number of these patients had higher rejection rate, and the rejection, when it occurred, it could be nasty. So basically, while the majority of patients with belatacept do great, there is a minority that do not. And so if we could apply precision medicine in selecting out those who do not respond to belatacept, and this is an abstract that we are presenting at this meeting, whereby we wanted to try to define how can we select with a precision medicine approach the patients who are going to respond well to belatacept. And what we found that there is what we do when the patient come in for a transplant and before they get Bela, we get a sample of blood and we do immunotyping of their circulating lymphocytes. And what we found that the patients that had high levels of CD8 positive, CD28 negative cells had much higher rejection risk than those who did not have those cells. And the cutoff was 50%. And this, to us, made sense because belatacept blocks activation through the CD28 receptor. And therefore, if you have a lot of cells that are CD28 negative, it's not surprised that these are going to be resistant to co-stimulation blockade. And this is, I think, the first step in trying to actually immunologically, with the immunophenotype, maybe at some point molecularly, define the type of patient that should be on belatacept, and as importantly, make sure that we don't treat patients who should not be on it because they're going to be resistant with belatacept. And this will apply to several drugs that are coming down the pipeline. First of all, we have now reappraisal of IL-6 blockade. IL-6 has been around for quite some time, but now there is better appreciation that its effect on the immune cells, on endothelial cells, are important, that maybe if we inhibit IL-6, we can get better results, or even more important, or as importantly, combine IL-6 with some of the other biologic. We can have a better belatacept. Belatacept binds to the ligand CD80-86. It does block activation through the CD28 receptor, but also it blocks the activation of the inhibitory pathways. It also blocks Tregs, and there was a question about Tregs earlier, which I answered, but Tregs may play an important role in regulating the immune response. And belatacept blocks receptors that account for the survival, the fitness, and the function of Tregs. So if we have an agent that is more selective but produces co-stimulation blockade, and there are these monovalent anti-CD28 antibodies, I think that could be a step forward. Now, the other antibodies are the anti-CD40 antibodies. The CD40 pathway has been important and understood for a long time. And so now there are monoclonal antibodies that target especially CD40, and I'll show you an abstract that is being presented at this meeting. And also, of course, we need novel approaches to desensitization and AMR. For example, there's a new drug that has been published in New England Journal called IDAS. This is an enzyme that cleaves the immunoglobulin. So if somebody has donor-specific antibodies, the antibodies are cleaved and they're non-functional, so you can't transplant the patient. The problem is 2 weeks later, these antibodies come back. So we need a plan B so that we can do the transplant successfully, but we can maintain the patient free of AMR. Historically, we've always targeted the B cells, rituximab, IVIG, etc. Now there is a new generation of anti-plasma cell antibodies, anti-CD38 antibodies. And I think this is going to be the next step into securing better suppression of DSA by actually getting rid of the cell that produces the antibodies. And so this is a figure of IL-6 and its pleiotropic cytokines. So it affects B cells. It increases differentiation of effector cells, Th17 cells. It does affect the endothelial cells. In fact, Stanley Jordan published a study where he treated patients with chronic antibody-mediated rejection with the anti-IL-6 receptor antibody tocilizumab. We have used the same drug to treat patients with inflammation. In fact, we showed that we can increase Tregs in these patients with tocilizumab. And as I mentioned before, the anti-CD28 can be potentially very useful. We have two anti-CD28, lulizumab and FR104. I don't know where FR104 is going, but lulizumab, I think there's going to be a small trial to assess the efficacy of this very specific anti-CD28. I know at Emory yesterday they said they have a small trial, and at UCSF through the CTOT network, this is a NIH-supported trial, we're going to use lulizumab to see whether we can least affect Tregs while inducing therapeutic co-stimulation blockade. So as I said, the CD40 ligand pathway has been recognized to be very important for a long time. It does activate the co-stimulatory pathway. It does activate B cells and induces B cells to differentiate plasma cells and produce antibodies. And also, it acts on cells to release, on monocyte to release cytodestructive cytokines. So the initial approach was to block CD40 ligand. It's always better to target a ligand than a receptor, because you never know if you target the receptor before you block it, it can activate it. Unfortunately, the first antibody, and we participated with Alan Kirk on these trials, the first antibody to CD40 ligand was associated with the thromboembotic complication because CD40 ligand is upregulated on platelets. So now most of the interest is to target the CD40 receptors. And there have been a couple of antibodies, and they appear to be very safe. And in fact, at this meeting, there is an antibody from Novartis called CFZ533 that had a small trial in 51 patients. So the patients were randomized 2-to-1 to either receive a CNI-free regimen, so it would be the anti-CD40 with MMF and prednisone with basiliximab induction, compared to tacrolimus and MPA and steroid, again with basiliximab induction. The advantage of this generation of anti-CD40, the one of Novartis, that produces very high rates of saturation of the CD40 receptor. And in terms of endpoints, the efficacy endpoint between the two groups, again, small study, appeared to be comparable. But as you can see from this figure, again, when you have a CNI-free regimen, you always get the benefit of improvement in the GFR. And so hopefully the next step for Novartis would be to do a larger study and assess, maybe different regimen with this anti-CD40. And we hope, if we have good ideas how to apply precision medicine, maybe how to look at patients and see how big data could be used to analyze outcome in a limited number of patients, that would be a great step forward. So what are our SMART goals going forward, other than being replaced by robots? One is to prevent and treat DSA and antibody-mediated rejection. I think we're making progress, and I think the next generation of combination therapy, there's never going to be one drug that desensitizes totally or one drug that will treat AMR, but I think we have to have combination. And what I would like to call is not a minestrone combination, but a mechanistic combination of drugs, where you put them together because not they are at hand, you have them available, but because they make sense. They may interrupt the process, the injury, the downstream signaling at different levels or different cells. Number two, understanding the pathogenesis of inflammation and fibrosis and treat it appropriately. At UCSF, we're doing a study where we treat these patients with Tregs, and we see whether, in fact, changing the Tregs does have a beneficial effect, increasing the Tregs or improving their function. Optimizing immunosuppression, that's where, really big data and precision medicine going forward will have, I think, a very favorable impact. And again, finally, what I said is applying these two new buzzwords, but that have real benefits to transplantation. I mean, we would only, as Dory said, we're starting the beginning to catch up with what oncology has been doing for a long time, frankly. And I think it's high time that we do that in transplant therapeutics. So we're ready. We have a few more minutes. And do we have lots of questions?
We have a few questions.
Okay.
I'll start with a simple one. One is, should you measure cognitive function before transplant as a baseline? And I would say, based on what we've found, there's actually a surprising amount of cognitive dysfunction in our patients. And I personally would do it. And if anyone has any questions about how we do it clinically, feel free to email me.
I mean, several studies have done that. The big challenge is that from dialysis to transplant, there is such a huge improvement that when you start comparing immunosuppressive regimen, it becomes harder to see differences. Yes. Yeah. But maybe longer term, or maybe there is a subgroup of patients who actually will show you differences. But the big change is dialysis to transplant.
Yeah, and I think as an example of something that's clinically useful, if you know that the patient has some cognitive dysfunction, and when you met them in clinic, it didn't become that obvious, you probably can then guess that they will have some trouble with adherence, and then you can make sure that they have a mechanism in place to help them with their meds or something like that. So I think even a simple thing like that is worth that kind of a screening.
Yeah, good. Let's see, what else do we have? So you were at the center where there was a lot of desensitization. So there's this question about is desensitization usually partially successful?
I think desensitization in the context of what we're talking about today, we've learned a few things at a course level, right? So we know that the more donor-specific antibody you try to cross during a desensitization protocol, the more trouble you're going to have both in the short term and in the long term. So even though we know that the first-year risk of, for example, a positive cytotoxic cross-match transplant is much higher, when you look at 2-year, 3-year, 4-year, 5-year risks down the line among those who have survived that long, there is still a risk that goes on. So we know that as we try to take on higher levels of donor-specific antibody, there are more challenges in desensitization. Now, if we better understood the mechanism of that, and we better understood, and we had better prevention treatments for that, then we might see more improvement. But I think what's happening in desensitization today is people are starting to take on lower antibody burdens and then try to find better donors for people.
Yeah. Now, what we have found in our high PRA patients, because now the allocation system favors the highly sensitized, that in the group 99, 98 and higher, is that there are two groups: those who go to 100% with like 25 antibodies to antigens, and those who have over 100. And so the first group, it's easier to find them kidney with this allocation. The other group is much more difficult. So there's always going to be a group, I think, that may require desensitization to get a transplant.
Yeah, I agree.
I have a couple of questions about the transform. One question was infection rates in transform. Overall infections were significantly lower at 1 year and 2 years in patients who were on everolimus reduced CNI as compared to full dose CNI and MPA. But the particular reduction was most evident and statistically significant in the viral infection, as I said, because of the specific effect of mTOR inhibitors on immunity against viruses. So you will see lower CMV and BK in patients who are on mTOR inhibitors. And there was an associated question as to how about the increased nephrotoxicities and mTOR with CNI? Well, the whole purpose to use mTOR is to reduce exposure to CNI. And if you target much lower levels of dosage and target levels of CNI, I think you can escape that nephrotoxicity. In fact, the Transform study was evidence that you don't get nephrotoxicity because the GFR were compatible.
I'll address a couple questions. One was, why don't we just use big data to match all patients better at allocation? And that was actually an idea that came up about 15 years ago in the UNOS Kidney Committee. And the compromise plan was to use big data a little bit to match people with better KDPIs to people with better what they call EPTS scores. So I would say that we are very coarsely using big data to try to match longevity between donors and recipients, but actually using it in a more granular way seemed actually not appealing to the transplant community for multiple reasons. There's another question that says, great talk, can we keep the iPad? And I'm quite certain that the answer to that is no. And then there's another question that says, when are these tools likely to reach the clinic for use of physicians? I will say that there are live donor kidney risk calculators. There is the Markov model for accepting or declining infectious risk donors. There are multiple tools that have come out of Rachel Spatzer's group at Emory. There are tools that UNOS is developing as well. Some of these are already in the clinic, and it's just kind of our responsibility to do this through what we call shared decision making, which is not to just tell the patient to put their numbers into a calculator and go figure it out for themselves, but to sit with them, look at the calculators, and then help them interpret what it is that we're seeing from there.
There is a question about the biopsy here, and I think this is an interesting and important topic. They say, how often do you do biopsy at 5 years? I think if we do protocol biopsy, we do them at 6 months. I think if you want to do biopsy to alter the course of the graft, to improve maybe long-term, to intervene materially with a change in immunosuppression, you should do biopsy in the first year. Because you can then see subclinical rejection, you may see deterioration in terms of fibrosis, you may see glomerular diseases, and that's the point to intervene. I think the 5 years, these are good outcome studies to look at pathology. The Mayo Clinic, the 5 and 10 year biopsy are a fantastic treasure of information. But I think in your daily practice, if you want to do a biopsy so that you can change your intervention to alter the course of the graft, the first year is the most important. Whether you do it at 6 months or 12 months, I'm not so sure there is a big difference. But this is a time when you can intervene. Of course, if you do, for example, studies or high-risk patients or desensitization, or where you have to follow more carefully what's going on in the graft, you may want to do those biopsies more frequently. And I guess we've gone through most of the questions.
Yeah, we got through a lot of them. It's 2:15.
And on time.
You have places to be. So thank you for your attention. Thank you, Flavio, for joining me on this.
Thank you. Thank you for being here.